Is my
Yes,
slides
ma'am, it is
visible?
visible.
Yeah, it is
Yes.
visible, ma'am. Visible.
Okay. So as I put in the chat, you can interrupt me anytime if you have doubts regarding the presentation. If you're not able to follow any of the slides, feel free to ask in between also. So the topic that is given to me is palliative care. To be frank, even I was unaware of this term palliative care as a medical professional until I was studying in my post-graduation MD psychiatry, where I got to know about a course in palliative care, and with that I got introduced into this field. Until that, uh, though the medical field is vast and specialized in multiple disciplines, even the professionals might not be aware of this term called palliative care. So I'm delving into such a topic which is a little far-fetched from the general population. So I would assume that this presentation will give a little more insights into what the general population is interested in. So we'll get into the topic. So when I was looking as what is the population or the audience who would be hearing to this presentation is mostly people who are not from the medical field. So that way I framed such a questions where any person who would hear this term would have as queries. So I'll be covering the presentation in these lines. First is getting to know what is palliative care and getting to know a little more, and uh, to understand who requires palliative care, and where is it available in India, and is it different from hospice care or long-term care or community care? How is it different from all this? And the services offered and the concerns addressed by the palliative care team when a person walks in with the expectation of palliative care. And the queries like, can my own doctor or the primary doctor provide palliative care? And some of the recent advances or the recent things that any person would have to know about the legalities in palliative care. So in these lines, I would be covering the presentation. So first, getting to know about palliative care. So rather than getting a textbook definition for me to present to you, I have just compiled it in a more practical terms. So palliative care is nothing but a holistic care, looking at a person as a whole, rather than looking at organ or disease specific per se. Okay, where we look at predominantly symptom optimization, particularly patients who have terminal illness or patients who have life-limiting illness, whose life-limiting in a sense may not be months or years. It can be any time with the diagnosis of life-limiting illness like heart disease or kidney disease or cancer conditions. So those kind of a patients who have high symptom burden, where the symptoms keep changing over time as the disease progresses. Those kind of a patients, the palliative care provides an optimal, holistic care, looking at the person as a whole. And our priority will be symptom management, looking at all the aspects: physical, psychological, social, and spiritual part of all the symptoms the patient presents with. And many times what happens when a patient has a terminal illness, for example, a cancer condition, which is very last stage or the stage 4, where the cancer has progressed to multiple different parts of the body, patient feels abandoned because specialists may say they have nothing to offer. At that time, the palliative care team has a role to play, because the disease, like cancer, has its own way or a pace of progressing. But as the disease progresses, the patients tend to develop a lot of symptoms. In that case, there is requirement of addressing those symptoms that is produced by the disease per se. Even though there is no treatment for the disease per se, sometimes patients can be managed with available medications, available therapy or the treatments, which can be provided to ensure comfort of the patient. So this is what the palliative care team looks at. So the principle of palliative care, many a times in the terminal phase, particularly when the patient has last few days in life, is like doing nothing very well, which means to say, many a times it's very important to assess the patient's distress level alone and address. So there might be multiple investigation which might be deranged. There might be multiple organs that might be affected by a disease, but only if the patient is suffering or has the distress attributable to that specific tests or specific organ, then better to address those symptoms is what the palliative care team looks at. So which is in a way termed as doing nothing very well, which means to say intervene when required, step back when not required. It's almost like that. So our goal ultimately would be to achieve the best quality of life when the patient has life, and ensuring the quality of death or the dying with dignity when it is almost approaching the end of life. So as I have learned from the specialists in the field, so one has to accept when the disease is progressive that death is not a failure, death is an eventuality or the natural process. So that way, to make a patient comfortable even in those last few stages is what we will try our best to achieve. I hope I am heard and understood. Is there any query related to this slide?
I mean, if anybody has got any query, they can raise it now, or doctor kindly permit us to raise it at the end also.
Okay, then do I proceed?
You, yeah, that will be so that we will fully listen to you, then raise the queries.
Okay, sir. So I'll go to the next slide, sir.
Please, please.
Okay, so coming to the next slide. So what does a palliative care team constitute and how do they work? What do we do? So generally, a palliative care team is a multidisciplinary team which has a doctor, a nurse, a psychologist, a social worker, a pain specialist when available, and a physiotherapist. So when you look at the whole array of professionals who form the multidisciplinary team, you could sense that they would be able to address a lot of dimensions of symptoms that the patient presents with, like the psychologist managing the psychological issues when they are in that terminal phase or when they have a life limiting illness, and the social worker looking into financial, the social or the familial issues, taking part in counseling regards to the goals of care, about the decisions about how to care them, all of it. The pain specialist, there is intractable pain. The doctors to take overall decisions about how to care about the patient, and a lot of terminal patients who are bedridden or patients who are having progressive illnesses will require a nursing needs, which will be taken care by nurses who are trained in palliative care setting, and the physiotherapists to ensure some amount of functionality is achieved even when they are progressively deteriorating. So this is what constitutes the team. And many a team, it may not be a different department in medical colleges or hospital. It can be a single person working as a freelancer, or sometimes it can be an integrated team into the oncology specialty or a cardiology specialty or a nephrology specialties. So a single member also can be palliative care physician providing care, utilizing the resources of psychologist, social worker in the main team like cardiology or nephrology. So it can be an independent department also, particularly in some of the medical colleges that I have come across. Currently, the recommendation from all the major guidelines that we have gone through is the early integration, which is nothing but palliative care team should be involved early on with the diagnosis of life-limiting illness or the progressive disease diagnosis, which means to say current practice, over the last few decades, what we have seen is referral to palliative care team comes only in the terminal stage when they have very few days or few months. But most of the guidelines in palliative care recommend integration of palliative care team early on in the diagnosis of any diagnosis with a life-limiting nature. That is the best possible thing that can be done if at all early integration happens. Sometimes because of the practice, we end up doing end of life care, where only the last few months when the disease has progressed to that level that there is no hope for the patient or the family, they would be referred to palliative care for symptom management and to ensure comfort during those last few days. And many a times palliative care, being a multidisciplinary team, is expected to provide grief counseling or post death of a person with terminal ill, the bereavement care for the surviving family members, to help them process the grief of loss of that person also. So usually our services are multi-pronged, mean to say, because the patients are terminally ill and they are bedridden, the feasibility of other specialties like the patient walks into a clinic or patients come for admission might not happen. So what is special about palliative care is we walk into the community to provide services through community care or the home care services, where many a times it is led by nurses. Where feasible, the doctors also accompany the nurses with physiotherapists and psychologists as the need may be. So patients who are unable to come to the healthcare services are also able to receive the palliative care through home care services. So the other usual services which happens in any other medical setup, like admissions in inpatient and follow-up on outpatient, all of it happens. And many of you would have come across this term called hospice, where patients who are almost terminally ill, who knows where the death is nearing, like six months or less, that kind of a patients can be put in places who are providing end of life care services. So it is mainly for cancer patients, but it's also open for other terminally ill patients. Bereavement care, as I already described, this is to support the family members process the loss of the terminally ill patient, and other services like rehabilitation, particularly the physiotherapy needs of the patients can be taken care. Spiritual care, many a times when the disease is progressed and there's no curative treatment available, patients will go through a phase of spiritual crisis or existential crisis, where you have questions like, why me? Is this a punishment? Why has God given me such bad disease? So those kind of a spiritual concerns will also be addressed in palliative care. And one of the other service like daycare, where it cuts down a lot of cost or the financial concerns, where in daycare, where the patient can be brought in for one day and optimize the most distressful symptoms in one day and relieve them back to their home and follow up through any of the other service like home care or outpatient is what we also follow.
Doctor, just 1 minute, I'm just stopping you here. See, Dr. Mahesh, who is also a geriatrician, he is from Dehradun. He has joined the group and he has joined the meeting. He has just raised one question, because you have been talking about spiritual. I just thought of raising that question. Madam, please share your experience of palliative care in spiritual dimensions. How do you approach patient's answer after? How do you approach this?
Sure, sir. I'll take it up at the end.
Okay.
Do you want me to discuss now?
Because it was there in the presentation, because you have said about this I just thought this will be a good time. That's the reason.
Yeah. So, yeah, first of all, identifying the spiritual crisis. As I said, usually um, you will rule out other causes like depression, denial, denial of the disease, all of it, and they actually have a real crisis or the query about why me? Why was I the chosen person for this suffering? Or uh, for like you would see that many of the cancer patients, if at all there are facial lesions or the breast lesions, they would be isolated, stigmatized. So all of the one, the disease per se, two, the reaction of the family member, three, they are unable to do their routine, means they are not themselves anymore. So all of it will put them into a state where why me, or why is this they are trying to like find an answer to the question as why this happened to me, and trying to attribute to different reason. Is it the past sin? Is it the God's punishment? Is it am I not a good person? There are many queries that surround the diagnosis of a terminal illness. If when this happens, like many a times addressing the distressful symptoms, if the patient is suffering because of pain, address that. If the patient is suffering because of the financial issues or the family issues because of the illness itself, address that. Many a times handling those kind of a circumstantial things will make them realize it's not a bad disease to deal with. It's okay to have such a disease. So at that time they find probably an answer uh, to this suffering is not the worst that I've gotten. Initially, it will be a mostly a response to the diagnosis that is revealed to him. And over time, they go through that phases of grief, of denial, anger, bargain, and they come to a stage of acceptance. And the source of support they get, they somehow get reassured and realize that it's an eventuality that I have to accept. Usually, that will be the course that will happen. Sometimes, a lot of like patients who are very religiously connected, getting into a spiritual dialogue or the religious dialogue of why you feel so. Maybe this is not that the God wanted to punish you. Having a open dialogue with the patient to elicit why he feels so sometimes lightens down the intense emotion that would have created that existential crisis. This is the way we approach generally, sir.
Thank you. Thank you, doctor. That helps.
Okay. Shall I move ahead, sir?
Please.
Okay. So if you ask a question as who requires palliative care, I would say any patient, even the elderly who are frail, elderly who just had a fracture in the spine and is bedridden, even it need not be a diagnosis. Means to say, any patient who wants care because of any issues can be choosing palliative care, particularly when they feel the specialists are not able to address those concerns. So diagnosis is always not a necessity to receive palliative care. We, in fact, provide palliative care to a lot of old age elderly who are bedridden, and because of the bedridden state, they have a bed sore, they are catheterized, so they require a lot of nursing needs. So those kind of a patients also may benefit from palliative care. So the question is is not who requires palliative care. The question is who actually chooses it, who wants it. So even the uncontrolled pain in a patient who walks into a pain and palliative care, though they are not receiving palliative care, at least their core concern of pain is addressed. So any patient who chooses it, the door is open for the symptom management in particular. Okay, and uh, the dictum is any patient who is diagnosed with life-limiting illness who are usually referred by specialists to palliative care. But from the age-old things, what we realize is it purely depends on the specialist who refer. Means the specialist from the oncology team, the specialist from the cardiology team, they should have an attitude towards palliative care. So as a medicos, when we are trained in a certain field, all of us as specialists have many things to offer, but not everyone looks at the person as a whole. Means to say, if a patient is almost bedridden and if he has a necessity for a surgical procedure, as a palliative care team, I still question whether this procedure has to happen because he's already bedridden. Is this procedure or is this surgery going to compromise his overall quality of life further on? Those are the queries I have as a palliative care. But usually the specialists who have a right attitude towards palliative care will go through, will have this question in their mind, and they would take an opinion from the palliative care team before intervening or doing any surgery. That kind of a thing happens. But many a times, it's the specialists who decide whether to refer to palliative care team or not. It depends purely on their attitude towards palliative care. And but it is also important that palliative care services is not available everywhere. So very few centers offer, which I'll describe in the further slides. So that way, when it's not available, so even though they require, who will provide it? That's the question. And the bias in the professional saying that palliative care is only for oncology or only for cancer care. It's not so. As I have been describing right from the beginning of the slide, it is for any patients with life-limiting illness. So we already discussed it's the hesitance from the primary doctor, and because it's an evolving branch, not everyone knows. As I initially described my experience, even I was not aware of the term when I was doing my MBBS. So not everyone are aware of, and it's a branch evolving. So there are myths, even in the educated, that palliative care means patient is in the terminal phase, so we should not refer. So those kind of myths are there, which holds the specialist back to refer, but it's not so. So at least with this presentation, I would assume some of the professionals in this forum and the general population understand that palliative care is not always a care during terminal phase. Okay, so these are the websites where you can look out for when you feel that a neighbor of yours or your own extended family members of yours requiring palliative care can look into to search for where are the palliative care services available. So this is one of the website. I will be able to share across the slides. You can click on this link and utilize the resources. So St. John's is one of the place where I work. The palliative care services have been provided for as long as some 5 to 6 years now. And there are other places like Baptist Hospital, Aster. These are hospitals in Bangalore where I am connected with. So you see, palliative care is across the country, particularly from one of the group called Pallium India. So they have centers across the country. So it's one step away from your Googling. So if you search for it, you will get it.
Can you just tell the name again? Pallium India, is it?
Yes, sir.
Pallium, Pallium.
Pallium India. It is by Dr. Rajgopal, who is one of the pioneer in palliative care. He's a Padma Bhushan.
Thank you. Thank you, doctor. Thank you.
So this is one other site. This is also one other site. This is across India, where if you go into this website and look for centers across country, you will be able to find the palliative care centers across India. Okay, so getting to the specifics of what is the difference between hospice care and palliative care. So palliative care, as we already understood, it's the comfort care or giving a holistic care for the patient in all domains of physical, psychological, social, and spiritual domains. It's the same thing, but it's until the end of life journey. But this is even at the stage of detection of the diagnosis. So both of them ensure the quality of life is good, but this will continue to care until the final stages. And hospice care, usually in the Western world, the criteria is if the treating specialist feels he has only 6 months further on after the diagnosis of this illness, usually they'll be sent to an hospice center if the care burden is high. Here, palliative care can start from the diagnosis and continue as long as the patient lives. And the treatment focus here will not be curative. Unlike here, even the patients with stage 1 malignancy, even the patients with stage 1 renal disease can be part of palliative care. And this will be provided in specific centers called hospice centers. One of the hospice center that is available in Bangalore is Karunashraya, which is open only for the cancer patients. But there are rehab homes, not specific for cancer. Like you would have heard about Atulya, old age home, and for dementia, the Nightingale's Trust, all of it. So these can be kind of hospice services for non-cancer conditions. So until what the hospice care is provided is until the patient passes away or patient chooses to discontinue hospice care. Here, it can continue as long as the patient lives, even during the curative treatments are going on. So these are the myths that generally any person who is a medico or a non-medico can have. Palliative care need not be only in the terminal phase. It need not be an hospice service. So palliative care is not just comfort measure. Even we look at curative aspects when necessary, like some parameters are deranged. We tend to follow it up and correct until and unless it is not harmful to the patient. It's not painful to the patient. If that is so, it's not just ensuring comfort, it's also a lot of medical aspects that we look into. So it's not giving up on the patients. It's like moving with the patient along with the process, how it is going. There are ups and downs, there are difficulties at random times, unexpected events, sudden events in terms of the course of the illness. So it's not giving up. So being through the journey with the patient, it's not doing nothing. It's about, as I said, doing nothing very well. When it's required, intervene. When it's not required, just be with them. Just continue to follow up on a OPD basis. But as the symptoms worsen, continue to care. So it's not for imminently dying alone. It's not only for cancer patients. And the biggest myth is there are no specialists. So palliative care should be provided by specialists alone. Nothing like that. So anyone who have an attitude to care for the patients, who has minimal formal training in palliative care, can also provide palliative care services. So as I was telling, right from the stage of diagnosis, even whether it is curative or end-stage disease, the palliative care can continue. And if it is curative, you lead them to rehabilitation. If at some point the symptom burden is high, you continue to manage symptoms. If you see that the disease is progressing and you are expecting that the patient will land up in ICU, it has last few days alone, you discuss about advanced care planning, how he has to be treated, or what is the best way to care for him with the patient before he progresses to a stage where he becomes incapacitated, help through the journey. And whenever they have a highest symptom burden or when they have shortest duration, like less than 6 months, refer them to hospice centers. And after that, continue with the bereavement care. And those who are in the curative intent mode, once the rehabilitation happens, they'll be in the survivorship. And if they wish to continue care with us, that will continue. So this is how the model of palliative care is proposed currently. So what are the concerns that are addressed in palliative care? One is pain, particularly, which is a common symptom in elderly, which is a common symptom in any life-limiting illness like cancer, like kidney disease, like dementia, like osteoporotic fracture. So pain is a common symptom. So this is one of the main symptoms that will be addressed, and other symptoms as per the disease. Those are the concerns that we'll be addressing. And mainly the patients with high nursing care needs. As I was describing, generally with the old age, if the patient becomes bedridden, they are not able to care for themselves. They don't know how to take care of mouth, they don't know how to take care of skin, because a walking, talking person is very different from a bedridden patient. So once your mobility is compromised, your muscles go into wasting, you will be at risk of multiple infections. So there's a huge need of nursing care when you are not able to take care of yourself. So that is something that the palliative care team provides through the help of nurses who are well trained in caring for a bedridden patient. We call it as head to toe care. So that is something that we provide for the patient, and we also teach the caregivers or persons who are not oriented in nursing care, even the routine caregivers who just have an attitude to care for a person can be called in and can be taught nursing care needs like right tube feeding, the urinary catheter care, how to care for the skin, how to care for the eyes, all the body organs. So those kind of things are something that we look at and teach them. And some of the psychosocial issues. So you would see that once the patient has terminal illness, a lot of financial burden accumulate, a lot of family conflicts start cropping up, a lot of issues related to property. Many things means because of the role change, many things go haywire. So we as a team try to handle in all aspects. So many a times the specialist might not have time to look into the psychosocial aspects or the financial aspects. So those are some things that will be left hanging, or the threads untied. So sometimes we do get referral to handle the psychosocial issues from the specialist. So we'll be called in. So that is something that we do. And chronic pain conditions, as I was saying, chronic neuropathic pains, herpes zoster, some elderly with immunocompromised status can have herpes, some infective condition which can cause pain. All of this, any chronic pain can be handled by us, and intractable symptoms in terminal phase. Where I can give an example where a patient who has metastatic cancer, whose disease is spread all over the body, he'll have bone pain, he'll have vomiting, he'll have fits or the seizures, he is bedridden, he has bed sore. There's so many things which are worsening, and all of it is causing patient like distress to the patient, where the patient is suffering. So we will try and address all these symptoms, particularly symptoms which are intractable. Means to say the normal regular treatments are not helping. In that case, how else to help? Like, is there a terminal sedation required? All of it is something that we give it a thought and decide. Some of the centers are specialized in providing palliative care for pediatric patients also, particularly where genetic diseases or global developmental delay, very severe mental retardation, very resistant blood malignancies. So all those childhood onset terminal illnesses, even those kind of patients also palliative care team handles, particularly who has some training in pediatric palliative care. So who can provide palliative care? Is it only the specialists who are trained in palliative care? Because you can see me, I'm a post MD psychiatrist, but I am in the palliative care field providing palliative care. So all physicians who have a training and attitude towards care for a holistic patient care can provide palliative care. Particularly, we look at some kind of a formal training in the form of CCEPC and FPM, which is available for all the post BSc nursing and post MBBS doctors who can undergo this training and are allowed to practice palliative care. They can set up a clinic and they can also have opioid available in their clinic with the help of the certificates that is provided by these courses, and they can start palliative care even as a primary care physician. So, however, the quality of care differs based on whether multidisciplinary team is available, whether the individual or the person who is providing palliative care has a person focus, not just the organ or the disease focus. Everything finally depends on that. So, what is expected in palliative care is to look at the person as a whole, like to achieve the best quality of life with the systems and the organs that is currently functional. So coming to the last slide, the legalities around the palliative care. These are recent developments, so I thought it's important for all of you to know. One
Yes,
is that the euthanasia. Yes, sir.
Yes, I kindly go ahead, ma. Kindly go ahead. It's very important. This legalities and palliative care is very important. Please go.
Yeah. So some of you might have heard the term euthanasia. It is actively ending one's life. Is that legalized in India? It is not. Okay. So many times we would come across patients who are diagnosed with terminal stage of cancer and they know they have few months, but the process of waiting for the death to come is itself is so psychologically burdening, and they inquire whether is there a possibility that I can end his life, or the physician can end his life, or he himself can end his life some way. So that is called euthanasia, but it's not legalized. So no doctors in India will be able to offer euthanasia. But a new recent bill was passed where there are recommendation on withholding treatment in terminal illness. Like for example, if a patient is in ICU and the patient is on ventilator, and once the ventilator is taken out, he's going to succumb. You almost know the outcome, that once the supports are taken out, he's going to end. So in that scenario, before I actually put the patient on ventilator, I still have a decision to make whether this patient is going to benefit from intubation or not, and withhold any life-sustaining treatment if you already know the patient is terminally ill. So I'll give you an example where you know the patient's disease is quite progressed and the disease, like the cancer condition, is everywhere. It's in the liver, it's in the brain, it's in the lung, his kidney is not functioning. You know most of the organs have failed, but only with an artificial support of intubation, you are keeping the person breathing. And once you have taken out the ventilator, he's going to die. That is well known to the treating physician. If that is the case, I have a duty to decide whether this ventilation or the intubation will actually add to the burden, not really do any good, and I can withhold the treatment. So that is a discretion of the primary doctor. But if that is to be carried out, there are legal systems in place currently where the primary doctor and the primary medical board, there are identified group of doctors and doctors in the hospital and a secondary medical board, an external group of doctors and the lawyers will make the secondary medical board, and they would be able to opine whether this patient can be withholded any life-sustaining treatment, or can this patient who is in ICU can be withdrawn from any life-sustaining treatment. So a group of physicians can decide whether any life-sustaining treatment can be continued or withholded. That kind of a recommendations have come, but there are logistics that still needs to be sorted, which the pioneers in the field are working on. So there are no solid guidelines or rules that are clear, but an arbitrary framework has been framed, which will take its own time for it to be in place. So that is one thing that I wanted to update to the group. The other thing is about the NDPS Act, which governs the opioid prescription practices, where, as I said, with a formal training, people can stock opioids. There are regulations how to stock opioids. Um, and there are many drugs, the opioid prescription drugs, which were previously so much controlled. Now it is liberalized to an extent for the benefit of patients who are suffering. So NDPS that way has transitioned in a many way, which is patient friendly compared to previously, where it was mostly controlling addiction or abuse of opioids. But now it is little more liberal and allows talking of opioids in an easy way. That is one thing. It's a good thing to know for India. And the fourth thing is about Ayushman Bharat. So many of you would have questions as whether palliative care is covered under Ayushman Bharat, because you have seen many patients availing this benefit in many of the medical wards. But as of now, I don't have a proper answer, but there are currently efforts from the major bodies in palliative care, like Indian Association of Palliative Care and the Pallium Group. All of it are working towards like including palliative care package under Ayushman Bharat, which is on its way. So it will take its time. So these are things that I wanted to bring up in the discussion. I know some of the topics might be too complicated for you to understand, but I have 10 more minutes to take up any questions which all of you have.
Thank you, Doctor. That was an excellent presentation. It was excellent. I think it has cleared, I think, if not all, many of our doubts have been cleared on that. Doctor, but one thing before going to opening the meeting for all, one thing I like to know, have you got any idea about the costs of this palliative care vis-a-vis hospice care? See, because this cost is one aspect that people also need to take into account before before they can take a decision on that.
Is it about cost, sir?
Yeah, cost. Yeah, yes, doctor.
So that's what, like, if it gets included under any insurance schemes, that would be great. But from my understanding, there are no insurances that covers, except for some CGHS, ESI to an extent covers palliative care, particularly how the doctor handles it. Means they have to term the diagnosis and treat them rather than simply terming as supportive care. They have to term it as specific diagnosis and ask for approval from ESI and CGHS. That will be covered. But with respect to out-of-pocket expenses, I feel compared to a general medical ward, we don't investigate a lot. We don't ask for any major interventions or major investigations where we would have already clarified as what level of care or what amount of invasive procedures they are okay to do. So that way we don't get into unnecessary investigation follow-up. So that way the cost of care will be much lower than any other medical wards that I would
But
think.
will not hospice be still cheap?
Sorry, hospice?
Will it not? Will not hospice care be little more cheap than palliative care?
So from my understanding, Karunashra is the only hospice which is available in India. I think they have 3 or 4 centers. So other than that, I don't see any major hospice caring for other non-cancer conditions. So that way I won't be able to tell whether it's costly or less costly, because Karunashra is a free service.
In Karnataka, it's a free service. This hospice care.
Karunashra is a free service.
Hospice. Before, sir, one day, just one minute, sir. Tangra, sir, 1 minute. Just the last only one question, Madam has asked, Lakshmi Raman has asked, any volunteer course offered to palliative care in Bangalore? So supposing we are volunteers, we like to get trained in palliative care. Is there any course available?
So there are support groups, there are volunteer groups, not really training, but they share their experience and continue to care, support, mainly in terms of psychosocial aspects of care, particularly led by Kidwai. I've heard about Kidwai running support groups and group activities.
So in fact, Dr.
Volunteers can volunteer.
Yeah, one doctor from Kidwai has joined, but he has just left. Dr. Shankar Anand, he is a professor in Kidwai. He was also there in the meeting. I just wanted to ask him, request him to talk something about that, because you have been talking about cancer. I just wanted, but he has just left. Just 1 minute back, he has left, because I think, and it's also very heavily raining in Bangalore. So that is also one more thing. So thank you, doctor. See, Tangra sir, you can now ask your questions.
Good evening, doctor. Please see my suggestions or queries in your chat box. Many government hospitals are looking after this palliative care, because most of the poor people cannot afford the cost of the expenses in private hospitals. The nurses' care is very essential, as you said, in a home or hospital. Whether any nurses can be available in home in a normal expenses to take care of the senior citizens who are cannot be cured, as you said. Counseling is also very important, because they want some good words before they leave the world. Some relatives and friends, they want to have side by side and want to console or counseling like that. This is the way people lying in bedridden. I am having such cases in my area. Feeling pain could not be controlled, or how to deal with the painkiller like that. The treatment can be terminated, but the pain, what is the relief for the pain? They are in the last moments. These are all my questions. Thank you, Doctor.
We'll start with the last one, sir. There are specific ways that we assess what is the reason for pain. And we follow something called WHO ladder. Like if one medicine is not helping, we'll go to the step 2. If that is not helping, we'll go to the step 3. There are different types of medication at different steps. So ultimately, in the last few days, you should have a painless, peaceful life is what we expect. So that way, even if medications are
even they cannot express their pain.
That is there, that we would assess based on their facial expressions,
Yes.
from the way they appear. With that, we would be able to gauge, even if they are not able to open their mouth and tell, we would be able to figure out patients who are unconscious and having pain.
Yes.
Those patients also we address. So it's a medical stuff. We have a certain way to titrate medications. We would ensure that the safest medicine in that terminal stage is also providing them relief of pain. That is one. Second thing about the first question is about government hospitals providing palliative care. One that I remember is Kidwai. and CIP, all of, not CIP, sorry, Christian Medical College, CMC in Tamil Nadu, that also provides. These are two that I am aware of. But as I said, I had posted some of the website groups. No, in that you can cross-refer as which center is linked with the government hospital. Then you would be able to figure out which is the free service that is available across the country. Your third question, second and third question, I forgot, sir.
So can you tell me the second question, sir? Second and third question. Doctor is
nursing cares in home.
So yeah, I understood. So nursing care, I know it is very costly business because you are hiring one human resource for the care of patient. Generally, what we do is orient the family caregiver only to take care of the nursing care needs of the patient, where you don't have to pay for an external person, where they would cost around 20,000 per day for a full-time nursing care to provide. So sometimes we take over patients from other medical wards to train the family members in nursing care. So that saves a lot of cost. So that's one way we can look at.
Thank you, Doctor.
Yeah, thank you.
Any other person has like to ask any other thing? Any other person would like to ask any other doubt? Any other matter? Subramaniam sir, would you like to ask anything?
Nothing.
You are unmuted.
Nothing.
You are unmuted. Any other person, sir?
So I didn't put up something in the slide. There's something called Advanced Care Directive.
Yeah, advanced care. That is okay. Thank you, doctor. You are
Advanced care planning, which might have been discussed by other people who are presented in dementia care, all of it. So just to introduce a little bit about advanced care planning, where a person who is still having capacity to decide on how he has to be cared in the terminal phase, if he fears that I would be incapacitated later point of time where I won't be able to control what is happening to me, my body, my life. So there's an option where you can make a legal document of how I have to be cared in the terminal phase. So that can be notarized and provided to the primary physician or the family physician whom they very well know, and leave it with the family member and inform the family members that if I don't, like, I have a choice to decide that I don't want any ICU care when I have this terminal illness. I can decide I don't want any major surgeries in the last phase of the illness. I don't want a pipe to be put in the mouth, in the nose to be fed. All of it can be explicitly mentioned. These are all matters of dignity where you may not feel uncomfortable to be placed elsewhere in an isolated setting in an ICU in the terminal phase. Some patients chooses to stay in the home or stay with the family members, close to the family members. So some patients take this decision well ahead before they have this terminal phase and make such a legal document. So that is also one thing that as a legal aspects in palliative care we could look into.
Latest thing is that government of Karnataka has announced that one can take some kind of euthanasia is possible, provided, so as you rightly explained, so many legal formalities are completed. That is the latest thing they have announced, because Supreme Court has given it direction to the states to form a policy on that. See, they have formed a policy, but I am yet to see whether anybody is able to use that and take care of that. Take care of themselves. But the advanced directive is perhaps the best thing. That in case I am not okay, in case other people have to take a decision about me, they are always in a dilemma whether this person should be given advanced treatment or whether treatment may be withdrawn, because they themselves do not know. They do not like to be tomorrow blamed by other relatives. Therefore, if I myself say that, okay, if I am not well, don't give me any invasive treatment. I want only non-invasive treatment in my lifetime. So better not to give that, and doctors are bound to act on that. But one thing is that normally we also hear is that people do not listen to this kind of directives also in some of the hospitals at least. And in some of the hospitals, people say that I am the doctor, you are not the doctor. You don't ask me what I should do. You don't tell me what I should do. I know what I have to do. So this kind of a, dilemma also comes in, doctor. That is one complaint normally we face from the middle class, especially the middle class.
Yes, sir. So we have a document in our hospital, means in our department, which we have framed such a way that not properly an advanced care directive, but it's a way to communicate to any doctor to say that I don't want this kind of an invasive treatment. I am currently under palliative care. I am going through comfort care. I don't want ICU care. That kind of a thing has been explicitly stated, and they have signed it. Many times it works because it has been signed by the patient.
Yes, doctor. When they sign that, can a normal person sign that document? We cannot, isn't it?
No, whenever they come to a hospital setup like us.
Only when they are in the palliative care section, they can sign that document. Until such time, they cannot sign the document. That helps. Doctor.
Yeah.
Thank you. That's a very good information. Doctor, incidentally, you have recently started, St. John's has started geriatric unit very recently. Say, maybe about a month. Are you connected in any way about that geriatric unit, doctor?
It's not fully functional yet, sir. They've just started on a trial basis in the initial few floors. It's mainly looking at the long-term care for any diagnosis. Somewhere who requires a nursing care needs, somewhere who requires a daycare service. So all those kind of patients they are ready to take in. But the systems are not in place yet. They've just started off, and it will take some time.
Yeah, because St. John's is one of the best hospitals in Bangalore, I should say. Why in India? So when something is done by St. John's, it is not only very good treatment, it is also cost effective. In today's context, what is happening, doctor? Any geriatric care is very expensive. You have been mentioning some names about where end of life care can be done. So there are minimum they charge 1 lakh per month. And we really do not know the quality of care that is provided. That's all too much for a normal person. So, as Tangrai sir has raised, I think probably the end to this road is when you are able to train volunteers like us who are willing to work. And you give some kind of training to us and some kind of certification so that we can also try to take care of at least 3-4 people in our own area. That at least is possible. But anything we need to walk a lot of miles. Thank you, doctor. It was an excellent presentation. Thank you.